Most doctors tell their patients over 60 to take their blood pressure medication in the morning, same time, every day. I did the same thing when I finished my cardiology residency. I repeated that instruction without question until one Tuesday afternoon, reviewing a 24-hour blood pressure monitor report for a 73-year-old man who had suffered a stroke with no clear explanation. I was sitting in front of that screen, and I went quiet for several minutes. His blood pressure during the day was perfectly controlled. But between 3 and 6 in the morning, while he was sleeping peacefully in his bed, his pressure was climbing to 178 over 104. And nobody knew, because nobody had measured it. Nobody had changed the timing of his medication. For 4 years, he had been taking his pill at 8 in the morning, exactly as instructed. What I'm about to explain to you today may permanently change how you think about that small daily ritual, the moment you swallow that little pill for your blood pressure. My name is Dr. David Aid. I've spent more than 15 years working exclusively with hearts over 60. I've reviewed more than 4,000 24-hour blood pressure monitor studies in older patients. I've seen thousands of medication histories, and I've walked beside hundreds of patients through decisions that seemed minor on the surface, like what time to take a pill, and turned out to be anything but minor. The question I ask every single time I see an older patient whose blood pressure looks controlled on paper, but who keeps having unexplained cardiovascular events, that question is always the same. What time are they taking their blood pressure medication? And has anyone ever checked their nighttime pressure? Almost always, the answer is no. Nobody checked. Today, I want to walk you through what's really happening inside your cardiovascular system in those quiet early morning hours, why the timing of your medication may be leaving you exposed during the most dangerous window of the day, and what 5 specific things you should be discussing with your cardiologist right now. Stay with me. This applies to you directly. To understand why the timing of your blood pressure medication matters so much after age 60, I need to explain something that most doctors simply don't have time to cover in a 12-minute appointment. Your blood pressure is not a flat line throughout the day. It is a curve. In people with a well-functioning heart and nervous system, that curve follows a predictable pattern. Blood pressure drops between 10 and 20% during deep sleep, a phenomenon we call nocturnal dipping. Then, in the early morning hours, roughly between 6 and 9 a.m., it rises sharply. The body activates its cortisol-adrenaline axis to prepare you for the demands of the day. That morning rise has a clinical name, the morning surge. And in people over 60, the morning surge is the single highest risk cardiovascular window in the entire 24-hour cycle. Think of it this way. Imagine your cardiovascular system is a large water reservoir with a pressure valve. During the night, that valve is partially closed. Pressure drops. The heart rests. The vessel walls relax. But between 6 and 9 in the morning, that valve opens suddenly. Pressure climbs. The heart speeds up. Platelets become stickier. The clotting system activates. In a young heart with elastic, flexible arteries, that opening of the valve is manageable. In a 72-year-old heart, with arteries that have been losing elasticity for decades, that sudden pressure spike can be the moment something gives way. This is not coincidence. Heart attacks occur most frequently between 6 and 10 in the morning. Strokes peak between 8 and 11. This is not a statistical accident. This is circadian cardiovascular biology. And after 60, that biology becomes more pronounced, more predictable, and more dangerous. Now here's the central problem. Most oral blood pressure medications reach their peak concentration in the bloodstream between 2 and 4 hours after they are taken. If you take your pill at 8 in the morning, its peak action occurs between 10 and noon, by which point your pressure has already been dropping on its own for 2 hours and the morning surge has already passed. This is not a problem with which medication you are taking. It is not a problem with the dose your doctor prescribed. It is a timing problem, a cardiovascular timing problem, that nobody explained to you, and that, depending on your individual blood pressure pattern and the specific drug you take, may be leaving your arteries unprotected during the highest risk hour of your day. Before we go further, if this is already making you think differently about your morning routine, I want to ask you to do one thing right now. Hit that like button. It takes 1 second and it tells YouTube to show this video to more people who need this information. People just like you. Okay? Let's keep going, because what comes next is even more important. There is a second phenomenon that complicates the picture significantly after age 60, and this one causes actual physical harm that I see in my clinic week after week. It is called orthostatic hypotension. Up to 30% of patients over 65 who take blood pressure medication experience a drop in pressure of more than 20 millimeters of mercury when they stand up after sitting or lying down. 20 points. That is not a minor fluctuation. That is dizziness, instability, falls, hip fractures, loss of consciousness. Now imagine this. You take your pill at 8 in the morning and you get out of bed 20 minutes later. You are combining two things at exactly the wrong moment. The early absorption phase of the medication, when the drug is just beginning to work and its effects on your vessels are not yet fully predictable, with the moment when your cardiovascular system is already under the strain of redistributing blood against gravity. That double impact in an older patient is not theoretical. I see it in real people with real injuries. Let me tell you about Manuel. Manuel was 71 years old when he first came to see me. He was a retired electrician. He lived with his wife in a fourth-floor apartment, no elevator. His greatest pride was cooking Sunday lunch for his 2 children and 4 grandchildren. He told me that in our first appointment, with the specific smile of someone who has something worth protecting. Manuel had been diagnosed with high blood pressure 6 years earlier. He had seen 3 different doctors. The first prescribed enalapril at 8 a.m. The second added amlodipine because his pressure was still running high in the office. The third increased the enalapril dose. In clinic measurements, his blood pressure was sitting around 138 to 145 over 88. Acceptable for his age, they told him. But Manuel came to me because he had fallen twice in 4 months. Both times in the morning getting out of bed, both times without losing consciousness. Just a sudden dizziness that came out of nowhere. The second time, he hit his shoulder on the doorframe and spent 3 weeks with his arm in a sling. The first thing I ordered was a 24-hour ambulatory blood pressure monitor. Not an ECG, not an echocardiogram yet. I simply wanted to see what his blood pressure was doing during the 24 real hours of his actual life, not during the 5 minutes he spent in my exam room. The results were striking. Between 9 a.m. and 8 p.m., his pressure was excellent, an average of 122 over 76, nearly perfect. But between midnight and 6 a.m., his pressure was dropping to 98 over 58 at its lowest points. Deep nocturnal hypotension. And between 6 and 7 in the morning, the exact moment he was getting out of bed, his pressure was rebounding from 100 up to 152 in a matter of minutes, with no medication coverage during that critical transition, because the pill he had taken at 8 the previous morning had already lost most of its effect. Manuel said something to me at our second appointment that has stayed with me ever since. After we went through the monitor results together, he looked at me with the calm directness that older people often have, the kind that only comes from years of figuring things out. And he said, "Doctor, I always assumed the dizziness was from low pressure. I never thought it could also be from high pressure." He was right on both counts. We adjusted his regimen. We moved the amlodipine to nighttime. We kept the enalapril in the morning but shifted it 1 hour later, and I asked him to measure his blood pressure at 2 specific moments each day, which I'll explain in detail shortly. 8 weeks later, Manuel had not fallen once. 4 months after that, he called me to say he had walked up 4 flights of stairs without stopping. I want to pause here for a moment, because I want to hear from you. Has your cardiologist or doctor ever ordered a 24-hour blood pressure monitor before adjusting your medication? Or have all your dose changes been based only on readings taken at the clinic? Write it in the comments right now. I read them, and your answer matters because it will tell us how many of you are in exactly the same situation Manuel was in. Go ahead, I'll wait. And while you're down there, if you haven't subscribed yet, please do. This channel exists to give you the kind of information that actually makes a difference. What I'm going to share now are 5 specific adjustments I work through with every older patient who has treated hypertension but is still experiencing cardiovascular events, morning falls, or out-of-range nighttime pressures. These are not 5 things to do simultaneously on your own. They are 5 informed conversations to have with your cardiologist, armed with better information than you had before watching this video. Adjustment. 1. Consider whether your medication belongs at night. I know what you're thinking. Your doctor said to take it in the morning because it absorbs better and because you won't forget it. Let me ask you to consider something. The recommendation to take blood pressure medication in the morning comes primarily from pharmacokinetic studies conducted mostly in patients between 40 and 55 years old, predominantly men with uncomplicated hypertension. In that population, the circadian distribution of blood pressure follows a relatively predictable pattern. In patients over 65, that pattern changes significantly. Up to 38% of hypertensive adults over 70 are what we call non-dippers, people whose blood pressure does not fall adequately during sleep or may actually rise during the night. For those patients, the science of chronopharmacology, giving medication at the moment the body most needs it, can produce real clinical results. Here is the mechanism. Long-acting antihypertensives like amlodipine, losartan, or ramipril have duration profiles of 18 to 36 hours, but their plasma concentration peak, the moment they are most potent, occurs 2 to 6 hours after the dose is taken. If the goal is to cover the cardiovascular morning surge between 6 and 9 a.m., taking the medication at 10 p.m. positions that peak of activity precisely in that highest risk window. The practical protocol. Talk to your cardiologist about a trial of evening dosing, specifically between 9 and 10 p.m., of at least one of your antihypertensives, ideally the longest-acting one. During that trial, measure your blood pressure at 3 key moments: before getting out of bed in the morning, 5 minutes after standing, and just before going to sleep. Record those 3 values every day for 2 weeks. That sequence gives your physician information that is simply impossible to obtain from office visits. One important caution. This conversation does not apply if a thiazide diuretic is your only or primary antihypertensive. Diuretics taken at night can significantly disrupt sleep in older patients, and poor sleep carries its own serious cardiovascular consequences. The conversation also requires direct supervision if you have chronic kidney disease or are on 3 or more antihypertensives simultaneously. What I want you to take from this first point is this. The timing of your medication is not an administrative detail. It is a clinical variable that can mean the difference between covering or missing the highest risk hour of your day. Adjustment 2. You may be measuring your blood pressure at the wrong times. I know what you're thinking. You've been checking your blood pressure at home for years. You know how to do it. You bought a good automatic monitor. Here's the thing. 62% of the older patients I see in clinic are measuring their blood pressure correctly in terms of technique, but at completely the wrong moments. And measuring at the wrong moments is, in practice, the same as not measuring at all. After age 65, the daily variation in blood pressure can swing by as much as 40 millimeters of mercury between the overnight low and the morning peak. If you measure at mid-morning, when your antihypertensive is at peak concentration and your circadian rhythm is naturally descending, you will see numbers that look reassuring. Your doctor will feel the situation is controlled. Neither of you will see what is happening at 6 a.m. The protocol I use with my patients is this. Measure your blood pressure at 4 strategic moments, 3 consecutive days per month. First, before getting out of bed, sitting up in bed, medication not yet taken, after at least 5 minutes of being awake. Second, 3 minutes after standing fully upright. This is specifically to detect orthostatic hypotension. Third, between 6 and 7 in the evening, before dinner. Fourth, just before going to sleep. Those 4 measurements, done 3 days in a row each month, give your cardiologist a blood pressure map of infinitely more value than 10 readings taken randomly at mid-morning. One warning. If your pre-rise readings, sitting in bed before getting up, are consistently above 150/95, do not wait for your next scheduled appointment. Call your cardiologist that week. Those numbers in overnight rest in an older patient require evaluation before they become an event. Adjustment. 3. Controlled is not the same as protected. This is the distinction that matters most, and the one that most surprises my patients when I explain it. Controlled blood pressure means that in the moment it was measured, usually in the clinic, usually mid-morning, usually after you sat quietly for 5 minutes, the number was within the target range. Protected blood pressure means your cardiovascular system has active pharmacological coverage during the biological windows of highest risk. The morning surge, abrupt postural changes, and the period of nocturnal variability. In a 45-year-old with an intact autonomic nervous system and still elastic arteries, those two things tend to coincide. In a 72-year-old, they can be entirely different realities. The mechanism behind that difference is called age-related arterial stiffness. After age 65, the muscular layer of the arteries progressively loses its ability to respond to pressure changes with the same speed it once had. The baroreceptor system, the feedback mechanism that tells the brain adjust the pressure now, loses sensitivity at roughly 14% per decade after age 60, according to data from the SHEP study. That means fluctuations that a young cardiovascular system absorbs in seconds can last minutes in an older one, and in those minutes of unprotected pressure, the cerebral and coronary arteries are exposed. The practical action here is not something you do. It is a specific question you ask your cardiologist at your next visit. Doctor, do you have any data on what my blood pressure is doing between 5 and 9 in the morning? Have you ever ordered a 24-hour blood pressure monitor for me? If the answer is no, and you have been on blood pressure treatment for more than 2 years, that conversation is worth more than any dose adjustment made in the dark. Adjustment 4. The medication isn't failing. The clock is. I want to explain something that is one of the most studied topics in cardiovascular medicine, and one of the least applied in everyday geriatric clinical practice. The renin-angiotensin-aldosterone system, the hormonal axis that regulates long-term blood pressure control, has its peak activity in the early morning hours, between 4 and 8 a.m. The medications that act directly on that system, ACE inhibitors like enalapril, ramipril, and lisinopril, and angiotensin receptor blockers like losartan, valsartan, and telmisartan, are among the most commonly prescribed antihypertensives in patients over 60. Taking them 8 to 10 hours before their target hormonal system is most active significantly reduces their effectiveness during the window when it matters most. A landmark study called the MAPEC trial, involving more than 2,100 hypertensive patients followed for over 5 years, found that patients who took at least one of their antihypertensives at bedtime had a 61% reduction in major cardiovascular events compared with those who took all their medication in the morning. That difference did not come from changing the drug or the dose. It came from changing the clock. The practical protocol. If you take an ACE inhibitor or an ARB, ask your cardiologist whether that medication could be moved to the evening, ideally between 9 and 10 p.m. The specific advantage for older patients is twofold. It covers the morning surge, and it reduces nocturnal variability without the risk of abrupt morning hypotension that can occur when those drugs are taken first thing. One essential caution: if you have heart failure with reduced ejection fraction or diabetic kidney disease, any adjustment to your ACE inhibitor or ARB regimen must be accompanied by monitoring of creatinine and potassium levels in the first 4 weeks after the change. This is a medical conversation, not an individual decision. Please make it with your physician. What I want you to carry from this fourth point: the medication is often not what's failing. The timing is. We are almost at the end. And I have to say, if you've made it this far, you are exactly the kind of person who takes their health seriously. That matters. Please subscribe to this channel if you haven't already. Every week, I bring you this kind of evidence-based, practical information designed specifically for adults who want to understand their health at a deeper level. One click on that subscribe button, and you won't miss anything. Adjustment 5. The morning emergency signals that cannot wait. Before we close, I need to spend a moment on something that defines my entire approach as a geriatric cardiologist, and it is this: knowing when the information in this video applies to you, and knowing when something more urgent is happening that requires you to stop watching and get help immediately. If you are experiencing crushing chest pressure that has lasted more than 5 minutes and is not resolving, stop this video right now and call emergency services. If in the last 24 hours you have had sudden difficulty speaking, weakness on one side of your body, or vision that went blurry without warning, that is a neurological emergency, and it cannot wait. If you have experienced a fainting episode or a loss of consciousness, you need an in-person evaluation today, not tomorrow. If your feet and ankles are progressively swelling, and you are having difficulty breathing when you lie flat, that may be decompensated heart failure, and your cardiologist needs to see you this week. If any of those 4 situations describe you right now, this video is not for you in this moment. You need in-person medical attention before any adjustments are made. But if what you have is a question, if you have been wondering whether the timing of your blood pressure medication is optimized for your older heart, if you have noticed dizziness in the mornings, if your blood pressure readings at bedtime seem higher than expected, if your cardiologist has been adjusting your dose for years based only on office readings, then every word of this video was made with you in mind. Let's bring this together. Your blood pressure follows a biological curve over 24 hours. In adults over 60, the morning surge, that sharp climb in pressure between 6 and 9 a.m., is the single most dangerous cardiovascular window of the day. This is when most heart attacks and strokes occur. Most blood pressure medications, when taken at 8 a.m., reach their peak effectiveness between 10 and noon, after the morning surge has already passed. Up to 38% of older hypertensive adults are non-dippers, meaning their blood pressure doesn't fall properly at night, or may actually rise. These patients may benefit significantly from evening dosing of at least one long-acting medication. The morning combination of rising pressure, fading medication, and orthostatic demands when getting out of bed is a real and under-recognized risk in older patients. Measuring blood pressure at the wrong time of day creates false reassurance for you and for your doctor. Measuring at 4 specific strategic moments gives a clinical picture that is impossible to obtain any other way. Controlled pressure in the office is not the same as protected pressure during your highest risk hours. The MAPEC trial showed a 61% reduction in major cardiovascular events simply by shifting at least one antihypertensive to bedtime. Not a different drug, not a higher dose, a different clock. And the 5 conversations to have with your cardiologist are: the timing of your medication, how and when you are measuring at home, whether you have ever had a 24-hour blood pressure monitor, whether your ACE inhibitor or ARB could be moved to evening, and whether your blood pressure is controlled versus genuinely protected. Manuel walks up 4 flights of stairs now without stopping. He still cooks Sunday lunch for his grandchildren. He still has that specific smile. The adjustment that made that possible wasn't a new medication. It wasn't a higher dose. It was a 24-hour monitor that nobody had ever ordered, a medication moved to the evening, and a 40-minute conversation that changed how his entire regimen was timed. That is what this channel exists to give you. The conversation that didn't happen in the 12-minute appointment. The information that your doctor may not have had time to explain. The evidence that you deserve to understand. Your heart after 60 is not a failing system. It is a precise one. It responds to the right input, at the right moment, with remarkable resilience. You just need to know where to look. If this video gave you something useful today, please leave a comment below. Tell me what surprised you most, or tell me whether your cardiologist has ever ordered a 24-hour blood pressure monitor. I want to know. I read every comment. If you know someone over 60 who takes blood pressure medication, share this video with them. It might be the most important thing you send them this year. Like this video if it helped you. Subscribe if you want to keep receiving this kind of evidence-based, senior-focused health information every single week. And I will see you in the next video, where we are going to talk about something else that happens inside your arteries during sleep that almost no one over 60 has been told about. Take care of yourself. I'll be here. I'll